Garrett Preston Clark, D.O. Internal Medicine. Thyroid disease. Garrett Preston Clark, D.O. Internal Medicine. What does the thyroid do? Heart rate, respiratory rate, rate of caloric consumption, skin maintenance, growth, fertility, digestion, heat regulation. How does it do it? The thyroid secretes two hormones. Thyroxine, T4, major hormone produced by the thyroid, aka pre-hormone of T3. Triiodothyronine, T3, is 3 to 8 times more potent than T4. Most circulating T3 is derived from deiodination of circulating T4 in the peripheral tissues. Iodine, what? Dietary iodine is essential for both T3 and T4, about 150 micrograms/day. T4 and T3 are bound to thyroid-binding globulin, TBG, thyroxine-binding prealbumin, and albumin. 70% of T4 is bound to TBG, 20% to TBPA, 10% to albumin. Iodine, what? Pretty much all of T3 is bound to TBG. 0.04% of T4 is unbound. 0.4% of T3 is unbound. Free hormone is taken up by the tissues. Iodine, what? Oxidation of I biperoxidase. Iodination of thyroglobulin. Proteolytic release of HRMN from follicle. Peripheral conversion of T4 to T3, SO, iodine from blood, in follicle, I. Thyroglobulin dityrosin T3, T4. Bound to thyroglobulin, out of follicle. Peripheral conversion T4 to T3. So, the thyroid gland produces predominantly the prohormone T4 together with a small amount of the bioactive hormone T3. Most T3 is produced by deiodination of T4 in peripheral tissues. Alternative, inner-ring deiodination, IRD, of T4 yields the metabolite T3, the thyroid or secretion of which is negligible. Thyroid. Many factors affect conversion rate, including body's need from moment to moment and presence or absence of illness. Oxidation of I biperoxidase followed by iodination of thyroglobulin is inhibited by propylthiouracil methimazole. Peripheral conversion is inhibited by propylthiouracil. Chemical structure. Thyroid hormones continued. T4 deiodinated in liver and kidney results in T3 and reverse T3, inactive. Thyroid hormones poorly soluble in water, so 99% is protein-bound. The principal carrier is thyroxine-binding globulin, a glycoprotein synthesized by the liver. Iodine, essential for thyroid hormone production. Iodine is concentrated from blood via the sodium iodide symporter, so-called iodine trap. Thyroid-stimulating hormone. TSH, thyroid-stimulating hormone, is released from anterior pituitary. Controller of TSH secretion is thyrotropin-releasing hormone, TRH, from hypothalamus. Both inhibited by high blood levels of thyroid hormones, negative feedback loop. TRH-TSH thyroid hormone feedback loop. Hypothalamic pituitary thyroid axis. Hypothyroid, definition. Condition results when tissues are exposed to excess thyroid HRMN. Characterized by increased basal metabolism, goiter, and disturbances of the autonomic nervous system. Affects women 3 to 1 more than men. Hyperthyroid diseases. Graves' disease. Toxic nodular goiter, Plummer's disease. Toxicadenoma. Therapeutic-induced hyperthyroid, Lugol's, amiodarone, etc. Thyroiditis. Primary anal metastatic follicular carcinoma. TSH-producing tumor of the hypophysis, hypothyroid, common symptoms and signs. Heat intolerance, excessive sweating, and moist skin. Hyperactivity and tenseness. Weight loss, unintentional. Fine tremors, palpitations, and tachycardia. Infiltrative dermopathy. Ocular signs, including lid lag, exophthalmos, and conjunctival injection. Generalized pruritus. Hypothyroid, diagnostic workup. History and physical. Blood chemistries, including hormone levels and specific antibodies. Ultrasound. Thyroid scan. Fine needle biopsy, particularly with hypothyroidism associated with nodularity. Graves' disease. Autoimmune disease associated with the production of antibodies that bind to TSH receptors in the follicular cells of the thyroid and activate these cells to produce T4 and T3. These antibodies therefore simulate TSH. TSH has no part in this hyperfunctioning. Graves' disease, most common form of adult hypothyroidism. Peaks in third and fourth generations. Bilateral exophthalmos occurs in 40 to 50% of Graves' patients. Unilateral involvement is rare. Graves' disease T3 and T4 concentrations increased, TSH level decreased. Autoimmune antibodies to TSH receptors. RIAG TC99 meters studies are increased. Scans usually show mildly enlarged thyroid which concentrates isotope evenly and intensely. Graves' disease therapy. Treatment with antithyroid drugs, propranolol, propylthiouracil, methimazole. Long-term remission rate with conservative treatment is low, 30 to 50%. Propranolol beta blocker makes patient eumetabolic but not euthyroid. Graves' disease therapy, surgery. Surgery is the treatment of choice if patient younger than 21 years of age, is sensitive to iodine, or have very large goiters. Recurrence rate as low as 2 to 9% with a 3% incidence of hypothyroidism. Side effects, vocal cord paralysis and hypoparathyroidism. Graves' disease therapy, radioactive iodine 131. Ri 131 equals therapy of choice for women past childbearing years and adult males. No proven increase in incidence of carcinoma, leukemia, etc. 25% of patients will be hypothyroid 1 year after treatment. Incidence increases 2%/year for the next 20 years. Graves' ophthalmopathy. Most frequent extrathyroidal manifestation of Graves' disease. Fortunately, most patients with only minor involvement, amenable to non-aggressive treatment. Graves' exophthalmos. Infiltrative dermopathy of Graves' disease. Toxicadenoma, definition. Autonomous hyperfunctioning nodule surrounded by normal functioning tissue. Rarely two or more adenomas exist in normally functioning thyroid. No clear cause, neither antibodies nor TSH involved. Nodule must be 2.5 to 3 cm in size to produce hypothyroidism. Toxicadenoma, presentation. Symptoms and signs of hypothyroidism. No exophthalmos. No infiltrating dermopathy. The thyroid gland may be enlarged, but is generally of normal size. On palpation, a non-tender, mildly firm nodule is palpable. Toxicadenoma, diagnosis. T3 and T4 levels are elevated. The TSH concentration is decreased. Specific antibodies are absent. On radioisotope scan, the thyroid gland is usually of normal size. One hot nodule, rest of the gland is cool. So, what's a cold nodule? An non-functioning thyroid nodule/lump that does not concentrate radioactive isotopes in a thyroid scan and may be indicative of cancer. Remember, cold equals cancer. Toxicadenoma, treatment. Unless contraindicated, radioactive iodine, 131 I, higher doses are usually necessary. Production on hypothyroidism is rare. Toxic multinodular goiter, plumber's disease. Enlarged multinodular goiter found in areas of iodine deficiency in which patients with long-standing non-toxic goiter develop thyrotoxicosis. Range from a single hyperfunctioning nodule within an enlarged thyroid to multiple hyperfunctioning nodules scattered throughout the gland barely distinguishable from non-functioning nodules and ordinary thyroid tissue. Plumber's disease. A middle-aged person with 10 to 15 years history of an enlarged gland. The general symptoms and signs of hypothyroidism. Exophthalmos is absent. Infiltrative dermopathy is absent. The gland is enlarged and multinodular. Plumber's disease, diagnosis. The serum T3 and T4 levels are raised. The TSH concentration is decreased. No autoimmune antibodies are present. Scan shows an enlarged, multinodular gland. 1, 2 or more nodules are hot, overactive. Plumber's disease, treatment. Similar to treatment for Graves' disease. Plumber's disease is more resistant to 131I therapy than Graves', apparently because the nodules of low activity become active as the hyperactive nodules are destroyed and more TSH is released. Induction on hypothyroidism is rare. Secondary hypothyroidism. This term refers to hypothyroidism precipitated by excess TSH secretion by a pituitary tumor or by other tumors, for example choriocarcinoma, struma ovarii, etc. Clinical signs and symptoms same as other causes of hypothyroidism, without exophthalmos. The T3, T4 and TSH concentrations are raised. The thyroid is enlarged and the isotope uptake is diffusely increased. Hypothyroidism. Condition where insufficient thyroid hormones are produced. Two main types are distinguished: primary and secondary hypothyroidism. Primary hypothyroidism by far more common. Hypothyroidism, Hashimoto's thyroiditis, idiopathic iodine deficiency. Overirradiation. Hypothyroidism characteristics. Cold intolerance. Weight gain. Constipation. Lowering of voice. Menorrhagia. Slowed mental and physical function. Hypothyroidism. Primary hypothyroidism is characterized by a high serum TSH concentration and a low serum free T4 concentration. Patients with a high serum TSH concentration and a normal serum free T4 concentration have subclinical hypothyroidism. Hypothyroidism. Secondary hypothyroidism is characterized by a low serum T4 concentration and a serum TSH concentration that is not appropriately elevated. Differentiation must be made between pituitary and hypothalamic disorders. Hypothyroid, lab studies. Anemia, normo/micro/macrocytic. Dr. John Pimp question. T4 and T3 concentrations are low, and TSH concentration is high in the primary type. T4, T3 and TSH are low in the secondary type. Thyroiditis, inflammation of the thyroid gland. Classified as chronic, subacute, and acute. Can initially present as hypothyroidism, ramification may result in hypothyroidism. Shinya Hashimoto RIP. Hashimoto's thyroiditis, not the wrestler. A chronic inflammation of the thyroid with lymphocytic infiltration of the gland caused by autoimmune factors. Most common cause of primary hypothyroidism in North America. Women to men 8:1. Often, plus family history. Also, increased in patients with chromosomal disorders, including Turner's, Down, Klinefelter's syndromes. Hashimoto's, signs and symptoms. Painless enlargement of the thyroid gland. Examination reveals an untended goiter, smooth or nodular, firm, and more rubbery than the normal thyroid. Many patients have hypothyroidism when first seen. Other forms of autoimmune disease are common. There may be an increased incidence of thyroid neoplasia, particularly papillary carcinoma and thyroid lymphoma. Hashimoto's diagnosis. Laboratory findings early in the disease consist of normal T4 and TSH levels and high titers of thyroid peroxidase antibodies and less commonly anti-thyroglobulin antibodies. The thyroid radioactive iodine uptake may be increased. Later in the disease, the patient develops hypothyroidism with decreased T4, decreased thyroid radioactive iodine uptake, and increased TSH. Hashimoto's treatment usually requires lifelong replacement therapy with thyroid hormone to decrease goiter size and treat the hypothyroidism. Occasionally, the hypothyroidism is transient. The average oral replacement dose with L-thyroxine is 100 to 120 micrograms/day. Subacute thyroiditis, de Quervain's thyroiditis. Acute inflammatory disease of the thyroid, probably caused by a virus. Frequently a history of mumps. The gland shows giant cell infiltration but lymphocyte infiltration is absent. Female patients outnumbered male patients in a ratio of 3 to 6 to 1. Although the disease has been described at all ages, it is rare in children. Subacute thyroiditis. Sudden onset of sore throat, tenderness of the neck and low-grade fever. Gradual onset extends over 1 to 2 weeks and continues with a fluctuating intensity for 3 to 6 weeks. Thyroid gland is typically enlarged 2 or 3 times the normal size or larger and is tender to palpation. Often confused with pharyngitis or otitis media, subacute thyroiditis. Approximately 1/2 of the patients present during the first weeks of the illness, with symptoms of thyrotoxicosis, including nervousness, heat intolerance, palpitations, tremulousness, and increased sweating. As the disease process subsides, transient hypothyroidism occurs in about 1/4 of the patients. Ultimately, thyroid function returns to normal and permanent hypothyroidism occurs in less than 10% of the cases. Subacute thyroiditis, diagnosis. History and clinical examination. An elevated erythrocyte sedimentation rate. The T4 level is elevated, the TSH is low. The 131I uptake is down in the presence of elevated T4, and a radioisotope scan, 99 MCO4, shows a cool thyroid or the thyroid is not visualized. Subacute thyroiditis, treatment. In some instances, no treatment is required. Mainstay of treatment is analgesia. Initial therapy with aspirin or NSAIDs. May need corticosteroids. Levothyroxine may be useful in situations where the patient is not already hypothyroid due to the release of thyroidal contents into the circulation. Acute, infectious, thyroiditis. Rare. However, occasionally, ESP in children, a persistent fistula from the piriform sinus may make the left lobe of the thyroid particularly susceptible to abscess formation. Occasionally, acute bacterial suppurative thyroiditis occurs in children receiving cancer chemotherapy. Acute thyroiditis, etiology. Virtually any bacteria can infect the thyroid. Strep, staph, pneumococcus, salmonella, bacteroids, T. pallidum, Pasteurella, and Mycobacterium all documented. In addition, fungal infections, including Cryptococcus, have been reported. Most commonly, however, especially in children, infection of the thyroid gland is a result of direct extension from an internal fistula from the piriform sinus. Acute thyroiditis, presentation. Pain in the region of the thyroid gland, hot and tender. Unable to extend the neck and often sits with the neck flexed in order to avoid pressure on the thyroid gland. Swallowing is painful. Pediatric presentation more typical than adult. In general, no sign of hypo or hypothyroidism. Acute thyroiditis, treatment. Surgical removal of fistula tract in pediatric patients with communication with piriform sinus. Systemic antibiotics with broad-spectrum coverage needed for some patients. Must add fungal coverage in immunocompromised patients. Acute thyroiditis, prognosis. Some patients with thyroiditis, the destruction may be sufficiently severe that hypothyroidism results. Patients with a particularly diffuse thyroiditis should have follow-up thyroid function studies performed to determine that this has not occurred. Surgical removal of a fistula or branchial pouch sinus is required to prevent recurrence when this is present. Gretinism, hypothyroidism of the fetus or child causes. Iodine-deficient diet in mother or during early life of child. Thyroid developmental defect. Thyroid relates enzyme deficiency. Failure of descent during development. Transfer of antithyroid ABs from mother with autoimmune disease to fetus. Gretinism, clinical features. Impaired physical growth. Enlarged tongue. Mental retardation. Enlarged, distended abdomen. Gretinism. Amiodarone and thyroid. Amiodarone used to treat cardiac arrhythmias. Structurally similar to thyroid hormone, comprised of 39% iodine. Patients on amiodarone may become hypo or hypothyroid. If hypothyroid, stop amiodarone and give T4. Thyroid nodule. 95% of solitary thyroid nodules are benign. Thyroid cancer is typically present as a dominant solitary thyroid nodule, cold nodule on scan. Papillary carcinoma accounts for 60%, follicular carcinoma accounts for 12%, and the follicular variant of papillary carcinoma accounting for 6%. Fine needle biopsy is a safe, effective, and easy way to determine if a nodule is cancerous. Features favoring benign nodule. Family history of Hashimoto's thyroiditis. Family history of benign thyroid nodule or goiter. Symptoms of hypothyroidism or hypothyroidism. Pain or tenderness associated with a nodule. Soft, smooth, mobile nodule. Multinodular goiter without a predominant nodule, lots of nodules, not one main nodule. Warm nodule on thyroid scan, produces normal amount of hormone. Simple cyst on ultrasound. Malignant nodule characteristics. Age less than 20. Age greater than 70. Male gender. New onset of swallowing difficulties. New onset of hoarseness. History of external neck irradiation during childhood. Firm, irregular and fixed nodule. Presence of cervical lymphadenopathy, swollen hard lymph nodes in the neck. Previous history of thyroid cancer. Nodule that is cold on scan, shown in picture above, meaning the nodule does not make hormone. Solid or complex on ultrasound. Thyroid disease, review. Condition. TSH. Free T4. Free T3. Other. Graves' disease. Usually. Thyroid scan with diffuse isotope uptake. Toxic adenoma. Or normal. Thyroid scan shows functioning nodule and suppression of other thyroid tissue. Toxic multinodular goiter. Thyroid scan shows enlarged gland with multiple active nodules. Thyroiditis. Variably. Thyroid scan shows low radioiodine uptake, thyroglobulin level markedly raised. Factitious hypothyroidism. Low radioiodine uptake on thyroid scan and absent thyroglobulin levels. Pregnancy. Normal. Total T4. Normal free T4. Total T3. Normal free T3. Positive pregnancy test. Steroid therapy, severe illness, etc. Normal or NA. The tests. Best way to initially test thyroid function is to measure the TSH. High TSH level indicates that the thyroid gland is failing because of a problem that is directly affecting the thyroid, primary hypothyroidism. Low usually indicates that the person has an overactive thyroid that is producing too much thyroid hormone, hypothyroidism. The tests, recall, occasionally, a low TSH may result from an abnormality in the pituitary gland, which prevents it from making enough TSH to stimulate the thyroid. Secondary hypothyroidism. T4 tests. T4 circulates in the blood in two forms, bound to proteins that prevent the T4 from entering the various tissues that need thyroid hormone. Free T4, which does enter the various target tissues to exert its effects. T4 tests. The free T4 fraction is most important to determine how the thyroid is functioning, and tests to measure this are called the free T4 and the free T4 index. T4 tests. The FTI tells how much T4 is present compared to the thyroxine binding globulin. The FTI can help tell if abnormal amounts of T4 are present because of abnormal amounts of thyroxine binding globulin. T3. T3, no, the other T3. Triiodothyronine, T3. Most of the T3 in the blood is attached to the thyroxine binding globulin. Less than 1% of the T3 is unattached. T3 not used much in these parts. A T3 blood test measures both bound and free triiodothyronine. The end. References. American Association of Clinical Endocrinologists Medical Guidelines for Clinical Practice for the Evaluation and Treatment of Hyperthyroidism and Hypothyroidism. EndoCract. 2002 November to December, 86, 457-69. Bartolini L. Pinchera A. Mecoxi C. Management of Graves' Ophthalmopathy, Reality and Perspectives. Endocrine Reviews 2000, 21-168-199. Beers, Mark M.D. et al. The Merck Manual of Diagnosis and Therapy 7th edition. Merck, New York, 1995. Braunwald, et al. Harrison's Principles of Internal Medicine, 15th edition. McGraw, New York, 2001. Klopper J.F. Diagnosis and Management of Imidazole-induced Hyperthyroidism. SAMED J 1999, 89-453-454. Murray IPC and LPJ. 1998, Nuclear Medicine in Clinical Diagnosis and Treatment. 2nd ed. Churchill Livingston, Edinburgh, 136-142. O'Reilly D.S. Thyroid Function Tests Time for a Reassessment. BMJ 2000 May 13 327,245, 1332-4. Student BMJ. Interpreting Thyroid Function Tests. www.medicine.com